Welcome everyone to the Pediatric Ophthalmology and Ocular Genetics session. I'd like to invite Dr. Rashmin Gandhi, Dr. Sumita Agarkar, Dr. Soumya Basu. Please come up. Dr. Parikshit Gokte will be joining us in some time, so we'll get started with the session. And I'd like to invite Dr. Sumita Agarkar, who will be the first speaker. Dr. Agarkar will be speaking on the myopia update for the next 10 minutes. Thank you.
Yeah. I hope everybody had a lunch here. So I'm going to update a little bit on myopia, what's happening in myopia in children. So if you look at the talk, I would be talking a little bit on workup on these patients, a change in the instrumentation, what has happened in last few years, the change in interventions, the gaps in knowledge, and what is the translational research. So at one time we were able to probably, when you worked up these patients, we only used to ask cursory history. But now I think history is important, because your interventions will depend on whether the one parent is myopic, both parents are myopic, premature, child was born premature, or full term. So that builds your risk profile, because if both parents are myopic, child is 6 times more likely to develop myopia, progressive myopia, rather than if only one parent is myopic. So history is important. In the workup, previously, the workup consisted of mostly only cycloplegic refraction and maybe a post-pediatric test, but now we need to document a little bit more on myopia, children with myopia. You probably have to pay attention to axial length, keratometry, as well as central corneal thickness. We need to do a peripheral refraction using a open field refractometer if possible, or otherwise manually also it is possible to do it. We also look at binocular vision, which includes cover test and lag of accommodation mostly, because lag of accommodation is important for, again, from the intervention point of view. Some people even suggest doing a basic dry eye workup also. So what has changed among the so what is changed in our instrumentation? So at one point it was enough to do cycloplegic refraction alone, but with the newer interventions it's important to select the correct intervention, and you need peripheral refraction, which is using an open field refractometer, is an integral part of the workup. Choroidal thickness is also a dynamic factor, and it is affected by a number. At this point, there isn't enough data on how you will choose myopia intervention based on OCT or choroidal thickness. But this is something, it's probably in it's a work in line, it's a work in pipeline, and probably there will be more data and knowledge available in a few years. So thickness can either be measured with OCT or with a B scan. Wide field imaging, especially useful in younger children and indispensable if you are looking at a syndromic or very high myopia. And electrodiagnostics, of course, wherever indicated. So electrodiagnostics are indicated if vision is not improving despite wearing glasses, if one or another close members of the family have a syndromic loss of vision, if there is a history of consanguinity, in that case myopia, or if there is a presence of nystagmus, in all these situations probably electrodiagnostics become indispensable. So what is the update on interventions? So previously, our interventions were only limited to glasses or contact lenses, but now you need a little bit of chair time to, basically, in these three groups our interventions fall on: lifestyle modifications, pharmacological, and optical interventions. So what are the lifestyle modifications? Outdoor activities, sunlight exposure, both are known to be protective against myopia, or rather myopia progression. There are enough data and several studies which have shown that progression decreases if the child spends at least 2 hours outdoors. And both screen time again and excessive near work screen time have again been linked, are considered myopiagenic, and definitely increase progression. So that also probably you need to spend some time educating parents about handheld gadgets, about limiting the use of handheld gadgets, especially in younger children. Often we have seen ki the child is fed while showing the mobile, and that is probably not a great idea in future. Good quality sleep, at least 8 hours of good quality sleep is also considered as a, you should probably insist on these. So this is something which you, every patient with myopia, along with first prescription of glasses, you don't have to give a low dose atropine, but this is something you need to talk to the parents and all of these points. Now, pharmacological intervention, basically low dose atropine again, and in India it's only available in 0.01%, but you need in other countries it is available in 0.02, 0.05, and several other compounded products are also available. But in India, commercially available is only 0.01%, and it still is very, very effective, up to 60% reduction in myopia progression. Oral 7-methylxanthine is available only in some countries in Europe and has not been proved as effective as atropine, but to completion's sake, this has been tried. Now, coming to optical intervention, there has been explosion in the number of specialty optical devices. The most important of them are which produce a optical defocus, peripheral myopic defocus, which are into DIMS, which is a defocus incorporated multiple segments, and another technology is highly aspherical lenslets, which have been one is by Hoya Vision and another is by Essilor, and there is another Myovision which also produces this optical defocus, which is marketed by Zeiss. You have dual focus contact lenses, which are also only FDA approved contact lenses, which are available for myopia control, and that can be in a toric version also available. Then there is dot lens, which does not really produce a defocus, but it has these translucent dots incorporated in glasses which reduce contrast at the level of retina, and that is supposed to be a protective feature against myopia. Now, coming to orthokeratology, again this is the only intervention along with low dose atropine which is really seems to be having good results with as far as the myopia control is concerned. Orthokeratology involves a specially designed contact lens, wearing it overnight to flatten the anterior part of the cornea or central part of the cornea, and producing a peripheral steepening, which is supposed to produce a defocus and works in the same way like other optical intervention. So most of these optical interventions reported efficacy is between 50 to 60%. They are most effective if children who have relative peripheral hyperopia. That's why I said peripheral refraction is important, because these may not be very effective in children who don't have this peripheral hyperopia. We have 6-year data available for, and some data on rebound available for these optical interventions. So far, no major rebound has been noted. But 10%, but always you have to remember, whatever the intervention, 10 to 15% children are likely to be non-responders. And also downside in our situation is all these optical interventions are fairly expensive compared to anything else available, compared to say low dose atropine. Light therapy, this is an experimental therapy, and repeated low level red light has been used to produce myopia control, and axial length elongation over a period was 0.13 compared to 0.38 in children who wore a single vision glasses. So it is probably a promising alternative therapy, but more data needs to be available. What are our gaps in knowledge at this point? We don't know what is the mechanism of action of low dose atropine, and if there is any extremely long term effects which are associated with. We do assume that it stimulates the dopamine, which is but how exactly, which receptors are inhibited, there is a little bit of gap in knowledge on that. Again, atropine does not affect axial length elongation as much as it does. Effect is mostly on the cycloplegic refraction. So the protective effect of myopia control in terms of controlling the elongation, eye elongation, which leads to retinal changes and pathological mind, is it really going to be protective? We have to wait for some years before we can answer that question. Again, there is a little bit of question on what is the best strategy for children who don't respond. There is several alternative strategies mentioned, but there isn't enough evidence to support that this works better than the other. So, what lies ahead as translational research, scleral cross-linkage using both riboflavin with some red light, and we probably need to do some work on identifying children who are pre-myopes. Sorry, that's a spelling mistake there. And whether we need to intervene in high-risk children who are siblings of children who are myopic or who are born to both parents who are myopic. Should we start intervention before they become myopic? These are the unanswered questions at this point. Thank you for the attention.
Thank you very much, Sumita, for covering all the myopia updates so comprehensively, and also the gaps in the knowledge that we can further look at, for which we can get some answers. We'll actually move on to the next speaker, and then we can take some questions at the end of 2 talks and then move on. So our next speaker will be Dr. Soumyava Basu, and he will be speaking on pediatric uveitis and the newer management strategies.
Thank you, Dr. Manju, for...
So he's my colleague at LB Prasad, and he shares the office next door.
Yeah, and that's
so I know a lot about pediatric uveitis just because of that.
Yeah, I moved it. Yeah, and that's why I got the chance to speak here. Fantastic audience, very encouraging. So I'm sure all of you are very interested in uveitis, which is why, pediatric ophthalmology, which is why you are here. So I'm going to talk a little bit about pediatric uveitis and then move on to what's new. Because in general, the awareness about pediatric uveitis amongst pediatric ophthalmologists as well as amongst the uveitis specialists is quite low. So let's start with, what are the challenges with pediatric uveitis? It's a very insidious disease. There's no redness or pain, which is why the parents are often unaware of what's going on in the eye. And if there are no other systemic symptoms, by the time the parents bring the kid to the doctor, it's already quite late. Many a times the child would have a complicated cataract, band-shaped keratopathy, etc. So this is the main challenge that we deal with in pediatric uveitis. The other things, of course, are the difficulty in history taking, the lack of cooperation in smaller kids during the examination. The side effects of the medications, these are all growing kids, and both corticosteroids as well as non-steroidal medications have their side effects. The risk of amblyopia when there is long-standing cataract or corneal opacity, and finally the long-term disability. Remember, uveitis is not a short-term disease, especially pediatric uveitis. These are long-term diseases requiring long-term treatment, and therefore the disability is a big issue. So the first point I want to highlight today is that pediatric uveitis is much more than JIA. We typically think pediatric uveitis to be synonymous with JIA, but that's not the case. The study, the largest one published till date from the United States, shows that there is something going on in the back. Yeah. So this shows that JIA accounts for roughly 1/5 of all pediatric uveitis patients. There's a big chunk of idiopathic, and there are all those other things that are also happening in adults. They happen in kids as well. In this series, infections accounted for just 6% of the total number of uveitis, and toxoplasma appeared to be the most common. Of course, there are pediatric specific uveitis entities such as TINU and Blau syndrome. Now, this is the largest study published from India, from PGI Chandigarh, and again you see that JIA is exactly the same percentage, 21% from India, and a big chunk also goes to tuberculosis. And in general, the percentage of infectious uveitis is much higher in India, as would be expected. There are a lot of pediatric specific diseases, Kawasaki, TINU, Blau, but one disease that we have identified in India, and Professor Ratnam is responsible for that, is the trematode-induced uveitis. These are pediatric specific uveitis entities. Again, if you look at GIA as such, GIA is just it's a collection of multiple different types of conditions, from enthesitis related arthritis, which will typically cause a B27 type of disease, redness, pain, etc., to the most common type of GIA, which is extended oligoarticular arthritis. So, and then you have psoriatic arthritis, systemic arthritis, and each of these have a different prevalence of uveitis. What really matters is how soon is the onset of arthritis. If the onset of arthritis is less than 5 years of age, then the chances of having uveitis is very high. If it's a female, if the patient is ANA positive, again, the chances of having uveitis is also very significant. In general, in a kid less than 7 years age, we screen every 3 months till the age of 7 years. Now, this is something that we should remember for all our patients. What investigations do you do in pediatric uveitis? Unlike adult uveitis, where ANA and RA factor are not relevant at all in the diagnosis of uveitis, in kids, ANA is probably the most important test that you would want to do. The rheumatoid factor, incidentally, is protective. So if you have a rheumatoid factor positive kid, then the chances of that kid having uveitis is relatively less. The other tests are for determining the general health of the kid, and also sometimes you do tests like B27, MON2, or TPHA, depending on what kind of clinical features you are seeing in the child. Then for pediatric specific uveitis entities, for example, for the tubulointerstitial nephritis and uveitis syndrome, TINU, you would want to do a urine and serum beta-2 microglobulin. Remember, these are bilateral acute anterior uveitis. There are very rare situations where you will have a bilateral acute anterior uveitis, and TINU is one of them. A female in the second or third decade, you would want to look at the beta-2 macroglobulin. I'm sorry, that's a typo, it's a microglobulin. Then further on, you can do genetic screening for the autoinflammatory conditions, and I'm coming to that in a bit. There are precautions in interpreting these tests. For example, in kids, the upper limit of serum angiotensin converting enzyme is higher than what you have in children, so you have to keep these things in mind. For the treatment, you would want to stop both the topical as well as the systemic corticosteroids within 3 months. That's the ultimate goal. You do whatever possible to stop topical and systemic steroids within 3 months. Try to use IV bolus instead of oral whenever there is a recurrence, and just carry on with the systemic immunosuppressives that are typically started in these patients. These are usually methotrexate or mycophenolate. A subcutaneous route is always preferable compared to oral treatment, and sometimes for increased efficacy, you would want to combine methotrexate and mycophenolate. I'm coming to biologics in a bit, but in general, the approach should be to start biologics as soon as possible. Adalimumab and infliximab are the two TNF inhibitors that are commonly used, and you should never be using etanercept. The trade name for etanercept is called Enbrel. So any kid that has uveitis and has been started on Enbrel, you would advise the rheumatologist to shift from Enbrel to adalimumab or infliximab. Adalimumab is commonly available as Exemptia. Then there are other ones like tocilizumab, rituximab, and the JAK inhibitors, and we'll talk about it now. So the two new things that I want to discuss today are the use of biologics, which are more important in pediatric uveitis than any other form of uveitis, and the concept of autoinflammation, which unfortunately is still not well understood even by many uveitis experts. So this is a single slide that I have for biologics. When to use? The current guideline is to use it for non-infectious uveitis, that is refractory to methotrexate. And this is probably one of the very few uveitis entities that has very high level of evidence. This paper was published in NEJM, the Sycamore study, and later on the Adjuvite study. which tells us that the drug works very well in patients who are refractory to methotrexate, which is the standard immunosuppressive for these patients. The American College of Rheumatology tells that it is not yet indicated as a first-line therapy. You should start the patient on methotrexate first. After 3 months, if the patient is not responding, you move on to the biologics. As I said earlier, adalimumab and infliximab are the ones that are preferred. And if both of these are not working separately, then you move on to the IL-6 inhibitor, which is tocilizumab. There are no clear guidelines about when to stop the drug. However, one approach is to gradually increase the spacing. Now, for steroids, you would want to decrease the dose as you taper. For biologics, you increase the spacing from 2 weekly to 3 weekly to monthly, sometimes even bi-monthly when you are tapering the dose of the biologic. And while there are no guidelines yet, there should be a control of inflammation for at least a year before you stop the treatment. JAK inhibitors are the ones that are new, and they are useful because they are oral, so you don't have to inject these drugs, and that's why they are gradually coming into use more and more. The last thing I want to convey today is the concept of autoinflammation, and this is an activation of the innate immune system, unlike autoimmunity, which is a spontaneous activation of the adaptive immune system, which is the T cell response. There's a big spectrum of autoinflammation versus autoimmunity, and the ones at top are essentially autoinflammatory diseases, and you see just 15 seconds. So you see sarcoid and conditions like gout and GCA right on top as autoinflammatory diseases, while the ones such as rheumatoid arthritis, SLE come more towards the autoimmune diseases. So this is a big spectrum where and they kind of equalize in Behçet's disease and in the B27 spondyloarthropathy. So I hope this is conveyed. This is the most common autoinflammatory condition. We published the first case from India where it's called as Blau syndrome. It's a triad of uveitis, granulomatous dermatitis, and a boggy arthritis, which you see in the both knees of this girl. It's also accompanied by episodic fever, and it could be a familial form, which is called as a Blau syndrome, and a sporadic form, which is called as early onset sarcoidosis. So to summarize, there are many challenges in the diagnosis and treatment of pediatric uveitis, the most important of which is insidious onset and the lack of awareness. Pediatric uveitis has a lot of components other than JIA, and JIA itself is not just one disease, but a mix of many different types of diseases. ANA is mandatory in the investigation of pediatric uveitis, and we just discussed the emerging role of biologics and autoinflammation. Thank you very much.
Thank you very much, Dr. Soumya, for the extensive and comprehensive coverage of the pediatric uveitis, and it really shows your depth of knowledge and passion in uveitis. So I'm just going to quickly run by two questions, one to Dr. Sumita and one to Soumya. So Sumita, for non-responders for myopia, what is your approach?
There is not much data on it. There is only one study which is published by Paolo Nucci, which has come in 2023, where patients were not randomized, but all patients who came to him wishing for myopia control, they were kind of, depending on patients' wanting, they were put into three groups, either a defocus low-dose atropine or defocus glasses or combination. In his series, the children who were on combination did better. So on one anecdotal feeling is that probably combinations will work. And I think we are looking at a randomized trial in Shankanetralaya for children who are non-responders. The trial is registered and we are ready to launch in any time now, next week. So we should know in a year's time.
Thank you. So next AIOC,
what works best.
That will be our next update.
Thank you. That will be probably the results. Sure. Only thing is very difficult to find. It's a big sample size and to find enough responders is going to be a challenge. Non-responders, actually.
Yeah. So, Soumya, can I just ask you, with regards to biologics, when you say you start with the methotrexate or or mycophenolate, how early would you consider starting biologics, and do you base that on the clinical picture or the severity and say, no, this is a candidate who is going to respond better to biologics, let me not just waste time with other immunosuppression?
Yeah, so while the ACR guidelines tell you that you don't start with biologics, sometimes if the inflammation is very severe. For example, last month there was this kid who came to us with a vision of counting finger 2 meters at first diagnosis in the worst side. We straight away, have often heard a word called step ladder approach in uveitis. You go step by step. So in pediatric uveitis, you stop using a ladder and you move on to an elevator or a lift. So you straight have to go from the ground floor to the topmost floor. And those are the cases you would want to start methotrexate. Remember, you can't start the biologic alone. You have to give methotrexate along with that, because the methotrexate will prevent the formation of antibodies against the biologic. So depending on the severity of case, you may start it right in the beginning as well.
Okay, that's great.
Your experience, how has been your patients' compliance with biologics? Because in India, that's very expensive, and a lot of patients are not able to afford for a very long time.
True, but if you kind of balance it against the amount of vision loss and disability that comes with GIE-associated uveitis, I think most of the times you are able to convince the parents that this is really required.
Great, thank you so much. We'll move on to our next speaker, and I'd like to invite Dr. Rashmin Gandhi. Dr. Rashmin Gandhi is a very well-known neuro-ophthalmologist who moved from Sumita's city to my city. So, welcome, Rashmin. And he will be giving us an update on pediatric neuro-ophthalmology, what's new.
Thank you so much. Thank you, Dr. Manju, for inviting me for this lovely program. I just wanted to have a comment. I don't know whether there is any clinical equivalence. We have been doing some study on effect of different wavelength of light on pupil and on different subsets. And what we have found is that in myopes, in the age matched, they seem to be, the latency to reaction is much faster to blue light. And then the theory is that maybe blue light stimulates the retinal dopamine through IPRGC, and that's the reason why they probably are more susceptible, or they're more responsive to blue light. Is there any clinical equivalence or observation?
I don't know about that, but red light as well as blue light, both have been tried for myopia control. Of the two, violet light has not worked very well for myopia control, but red light, there is one article in ophthalmology which I mentioned, published in 2022. They have said that it does help in myopia retardation.
All right. Thank you. So my role is to talk about what's happening right now in pediatric neuro-ophthalmology. Well, the most exciting part which is going on in pediatric neuro-ophthalmology is all in genetics, which is a separate talk. So I'm going to maybe stick to something more clinical. First, let's have a little overview of what's going on in neuro-ophthalmology in general. The real change which has happened with the newer knowledge has been in the field of optic neuritis. The way we look at optic neuritis and the way we treat optic neuritis is quite different in the last 4-5 years, and we have understood more about this disease in last 4-5 years than in the previous century. The other optic neuropathies, there has been again some kind of knowledge addition, like LHON. We know that there is a gene therapy which is going on, and I'm sure Manju is going to talk about it. Idebenone has been used in LHON. It appears that it is safe, and maybe it has some impact on progression of the visual field defect, and in some instances even reversal of a visual field defect. AION more and more associations of non-arthritic AION have been now discovered. We know that amiodarone does cause something which a clinical spectrum which is similar to non-arthritic AION. Sleep apnea has been associated. So these are a few things which has changed in last 1 decade or so. Raised ICP in by and large is one disease where the distinction between pediatric disease and adult disease is by and large blurred. I mean, both behave quite in a similar way with a similar etiological factors. Though OCT has gained quite a bit of role, and I'm going to talk about that role of OCT in optic neuropathies and also in pediatric diseases. Cranial nerve pulses in last few years, again, there has been a shift towards ordering faster neuroimaging than what we were doing maybe a few years ago, because the chances of, if you miss a tumor in a patient who seem to be having vasculopathic risk factors, then you're probably doing more damage to the patient. The morbidity is much high. Diagnostics, role of OCT, we're going to talk about it. Therapeutics, there has been now a movement. We know that Argus 2 has been now clinically approved and is being used in the US for advanced retinal degeneration. Same company has come up with an implant, which now I think the trial has begun, which is now directly implanted into the occipital cortex. And they're hoping that it will work in a similar way, where somebody who is blind because of visual pathway disease probably gain some useful vision. So for pediatric neuro-ophthalmology, I'm going to stick to optic neuritis and some of the diagnostic challenges. Genetics, as I said, there is a separate talk. So optic neuritis, little more than a century ago, this famous at that time neuroscientist, Walter Bailey, thought that optic neuritis is because of accumulation of bad spirit within the head. And he said that we can probably suggest to these patients a particular procedure which will draw the vapors out of the head and remove it from the site, and the patients would improve. And what he suggested as a procedure to draw these vapors out was to comb the hair 3 times a day for these patients, and he thought that combing the hair will bring the vapor out. Obviously, he didn't think of certain group of patients, what happens to them if they develop optic neuritis. That's not Walter Bailey, by the way. What has changed in optic neuritis, especially in pediatric age group, is we were told when we were studying neuro-ophthalmology that optic neuritis is by and large associated with multiple sclerosis. It's a self-limiting disease in more than 90% of the patients, and whether you give steroids or you don't give steroids, it does not make difference at the end of 6 to 8 weeks. But now we have discovered antibody-mediated optic neuritis. I mean, there were always a group of atypical optic neuritis, but now we know why these optic neuritis behave differently. And we know that in Indian patients, these antibody-mediated optic neuritis is actually form the majority of our patients. There are 2 antibodies which we know or are aware of and which we test regularly. That is antibody to aquaporin 4 water channels as a marker for neuromyelitis optica, and the MOG antibody. Now, why it is relevant for our session today is that in older days, we used to say that optic neuritis is a disease of young adult female. But these 2 antibodies, the NMO, can occur at any age group. It is more common in middle-aged females. But there are multiple studies which have said that between 5 to 8% of children can also have optic neuritis because of NMO. Out of optic neuritis in pediatric age group, 7 to 8% can be because of NMO. So it appears that NMO can affect even a pediatric age group. And MOG optic neuritis, in fact, one of the predominant groups which can be affected by MOG antibody is children. So that's the reason why it's important for us to know for this session as to what are the features of antibody-mediated optic neuritis. Again, a typical optic neuritis, as it was described in the literature, was more common in Caucasians, than in Africans or Asians. But NMO is much more common in our population, and MOG can affect any race. What about visual acuity in disc? What's the difference between so-called typical optic neuritis and an antibody-mediated optic neuritis? The typical optic neuritis generally would have mild to moderate visual deterioration on presentation, while both NMO and MOG-mediated optic neuritis would have a severe vision loss. They also exhibit more disc edema than somebody who has a typical optic neuritis. And MOG is much likely to be bilateral on presentation than either NMO or a typical optic neuritis. What about progress and recovery? Typical optic neuritis, more than 90% of these patients would have a recovery even without intervention at the end of 4 to 6 weeks. And patients who have optic neuritis with a circulating antibodies to aquaporin 4 antibody, they generally have a poor recovery. MOG is somewhere in between. Most of the patients with MOG antibody would be more benign than NMO, and they will have a good recovery. So when do I suspect in children or in adults as to I'm dealing with antibody-mediated optic neuritis? Pain seems to be much more common. Patient complaining of pain seems to be much more common in a typical optic neuritis versus in antibody-mediated optic neuritis. Disc edema, bilateral presentation, or a severe vision loss on presentation are features of NMO or MOG. They don't respond to steroids so readily. So it might take 3-4 weeks for a patient to come back to normal. In typical optic neuritis, in these patients may not recover any visual acuity. Apart from that, these are some of the features which are fellow travelers with patient with NMO optic neuritis, that is weakness or paralysis of the legs and arms, painful spasms, loss of sensation, uncontrollable vomiting and hiccups. And that happens because NMO-mediated optic neuritis generally would have features which affects hypothalamus. And that's why vomiting or hiccups can be a persistent symptom. The treatment also differs now. We were told that even if you don't give steroids, really you are not really harming a patient in typical optic neuritis, but that has changed considerably. NMOSD in children in an acute phase, every child should receive IVMP of around 30 milligram per kilogram to up to 1 gram. And generally this steroid is given for 5 days. Children who are not responsive to this treatment, acute loss of vision may benefit. Remember, because this is an antibody-mediated problem. So if you demonstrate antibody in the blood, they may benefit with 5 to 7 cycles of plasma exchange. In fact, it is believed that early plasma exchange may prevent the occurrence of deadly neurological comorbidities like paraplegia. Children may also respond to IVIG, and that decision is something which we take in partnership with neurologists. So that's about the acute phase. What about preventive phase? What would you do in patients who have a circulating antibodies? Azathioprine seems to be a drug of choice with a lot of neurologists, and generally that's given for, in a MOG antibody, it's given at least for a year or more. And NMOSD, these drugs may have to be given for a longer period. If patient has a deterioration of problem or there is a new symptom while azathioprine is being given, then rituximab or mycophenolate are other options. There are new agents, some of which Dr. Soumya was mentioning, like tocilizumab. They all have been tried in NMOSD, and they seem to have some role to play, though we don't have any large study to confirm it. So that's about the NMOSD treatment. One of the indicators in children or in adults about NMO would be on MRI, where generally a long segment of the optic nerve is affected. You'll find white or hyperintensities in chiasma, optic tract, which is not a feature of typical optic neuritis. You also see these areas like area postrema or dorsal midbrain getting lit up, which generally you don't see it in typical optic neuritis. A slide about MOG, which has a similar spectrum as NMO, though probably a little benign than NMO. It has more, this is much more common. MOG-associated optic neuritis is much more common in pediatric age group. They can have an associated encephalitis, more bilateral, more monophasic. They have a better recovery. And again, MRI would give you a clue. NMO generally would have a long segment getting affected, while in MOG, there would be widening, the sheath of the optic nerve also gets lit up, and so they will exhibit perineuritis on MRI scan. Why all this is relevant for us is because a lot of these diseases now, ophthalmology would be guiding or governing or will be an important member of the team which will manage NMO, because we would be knowing whether patient has a disc edema, bilateral simultaneous presentation, profound visual impairment, which are pointers towards antibody-mediated optic neuritis. So that's about the optic neuritis. There have been some developments in the way we look for pupil. RAPDX, the objective way of checking pupil, is now commercially available. I know LV Prasad Eye Institute also has a pupil measurement tool, and which is an objective tool of measurement of an efferent defect, and probably will be very useful to be used in children. OCT, of course, one would argue and say that most of the machines don't have a normative database in children, and can it have any significant role? Well, there are researchers who are using OCT to differentiate pseudopapilledema versus papilledema, or it has been used even in optic neuritis. It is suggested that optic neuritis with macular star or neuroretinitis, sometimes in children the macular star takes a little time to form, but in those patients who are going to develop neuroretinitis, they can have a bright internal limiting membrane, and you know that you are probably dealing with an infective optic neuritis which will settle with antibiotics. In case of hydrocephalus, this is something which I fished out from the literature, where patient had 2400 vision, but RNFL, the average RNFL was normal, and the child was given a diagnosis of a functional vision loss, but then ganglion cell layer was actually completely absent. So patient actually had a problem. OCT to monitor IH and also visual in young patient. It's been published. IH monitoring with OCT is an objective way to say whether the optic disc edema is going down. You have a number to it, but we have the word of caution that disc edema might be going down either because patient is responding to your treatment and really the fluid is going down, or the disc edema initially is going down because patient is actually losing neurons, and that's why the average number is down. And way to differentiate between the two, whether patient is responding to treatment or not responding, is to have average RNFL with a GCC thickness. So in a nutshell, there have been now movements in a lot of diseases in neuro-ophthalmology. Most important part is in genetics, but there have been some changes now the way we deal with optic neuritis and the way we use OCT in these disorders. I thank you once again.
Thank you very much.
If anyone has any question for Dr. Gandhi, you can take that.
In your pediatric age group, have you encountered any case of Tulaza-Hunt syndrome?
Not me, but I don't know. Manju, Tulaza-Hunt syndrome?
The more I've seen in adults or in older teenagers, none less than 12 years of age.
I have seen 4 cases in adults. Basically, it's a kind of an inflammatory or autoimmune stuff of the structures which pass through the superior orbital fissure and the cavernous sinus. Patient complains of hemicrania, periorbital diplopia, and on examination you have a kind of a proptosis, ophthalmoplegia, and involvement of second, third, fourth nerve, and the first and the second division of the sensory, fifth is involved. The steroids are both therapeutic and diagnostic. I have seen 4 cases in adults, but I have seen in one case in a pediatric age group, and unfortunately, the 4 cases they recovered, but this girl didn't recover.
So these 4 were all pediatric?
No, 4 were adults.
Adults. Oh, we see a lot of adults. Adults,
yes.
But one of which case I saw was a girl where we gave her steroids, she did recover, and even the visual response was not very good.
Yeah,
so I've seen one pediatric age group with a Tulaza-Hunt syndrome.
Interesting. Though a word of caution in some of these patients, because of the area where all this inflammatory material is affected, some of these patients can be harboring even infection, which goes through the sinuses, and that's where we have to be careful with.
MRI is mandatory, and it has to be it's different diagnosis, sarcoidosis.
Yeah.
Rashmin, I had a question for you. In a case of a, say, 10-year-old, very young child, if you're planning to give an intravenous methylprednisolone, do you give it as 1 gram per day?
No, generally it's a 30 milligram per kilogram.
So suppose they weigh about 20 kgs, 25 kgs, it becomes much higher, no?
No,
Yeah,
600.
it is much lower.
600, yeah.
It is much lower.
Yeah, yeah.
So you reduce the dosage usually depending on the weight.
Weight, and generally we, most of these patients, we make sure that we do it in conjunction with a pediatrician or with a neurologist because you require monitoring.
So why I asked was the pediatrician told us you can go ahead with a 1 gram. We give it all the time for these renal patients.
Yeah.
Please go ahead. It is very safe.
Yeah.
So this, which is why I asked this question.
But a neurologist generally would prefer to say that we match it with the weight, though there have been reports saying that you can go easily with 1 gram and nothing happens. But we generally give this 30 milligram per kilogram.
I'm going to now ask Dr. Manju Bhate to give her talk on hot and happening ocular genetics update. I think genetic genes and genetic testing are going to be the way for future, and I think we all will benefit by learning a little bit more about.
Thank you very much. And this will be the last talk for this session as Dr. Parikshit is held up somewhere. Can I have my slides, please? Okay, so I'll be taking you through some of the ophthalmic cases and related genetics because, as we said, genetics is a very important part of pediatric neuro-ophthalmology. And since we all live in the genomic era, we should be aware and help our patients in making a diagnosis. So genetic testing has become a benchmark for the diagnosis and management of congenital and inherited conditions. And ocular genetics basically confirms the phenotype-genotype correlations in these varied conditions. And therefore, with the help of genetic counseling, we can bridge this gap and give a confirmatory diagnosis and a plan for the families. So let's go through some of these families that we see. So this is the first family. These are two siblings, the older boy and the younger girl. And if we look closely at their eyes, they do have some amount of ptosis that we can see, and looking closely, they have a very prominent Schwalbe's line. They have correctopia, which you can see. Also, they have malformed dentition. So here we are looking at family which is possibly having an Axenfeld rigor. Their intraocular pressures at that time were within normal limits, but also needed very close surveillance. So this is an autosomal dominant condition where it involves anterior segment dysgenesis and systemic abnormalities, as which include the ocular abnormalities of posterior embryotoxon, iris strands, iris hyperplasia, correctopia, polychoria, and the systemic dental and facial and umbilical features. So this family was then underwent genetic testing where we found a microdeletion in chromosome 6, and which was confirmatory for Axenfeld-Rieger syndrome. Let's move on to our next family. So these are two siblings. As you can see, they're really tall and thin, and I'm trying to sort of hint at a particular diagnosis that I'm considering in this family. They came with, excuse me, you're disturbing. So they came with complaints of reduced vision in both eyes. So as you can see here, the arm span is wide. They have tall, thin fingers. And the top two photos are of the older child, whereas the bottom two are the younger child, where you can see the marked ectopia lentis in both these children. So with the suspected diagnosis of Marfan syndrome, they underwent genetic testing, where they were found to be positive for the FP1 gene. The younger child underwent lensectomy first, and this was followed by a secondary intraocular lens implantation. So both the younger and the older child are then doing well with an iris claw lens. And as we see a lot of these suspected Marfan syndrome, not a lot of them actually are convinced to go about doing genetic testing. But what's important is to be able to give them a diagnosis, also get them systemically evaluated, especially for heart problems, aortic root problems, which can be life-threatening in these conditions. Next, we move on to these two siblings. So on the one on the right is an ocular cutaneous albinism. As you can see, it affects both the eyes and the skin, whereas the one on the left is a child with just ocular albinism, which is X-linked condition, whereas ocular cutaneous, which is autosomal dominant. Here you can see they're satisfying all the clinical diagnostic criteria of reduced vision, nystagmus, iris transillumination, hypopigmented fundus with foveal hypoplasia, as you can see in the OCT over here. So this was another child who actually came with a head tilt, or we can see an abnormal head posture. And what I just wanted to highlight in this is that not all abnormal head posture is nystagmus driven or poor vision driven. In this case, though he had the albinism and the nystagmus, he also had a very short sternocleidomastoid on the left side, which was actually causing that abnormal head posture. So we also looked at some phenotypic variations in siblings who present with albinism. This was one of our articles wherein we looked at the strabismus, the abnormal head posture, the refraction and the vision. And there is a wide variation which we noted in siblings who have oculocutaneous albinism. Next, we come to a family or a case of Leber's hereditary optic neuropathy. So this was a young male who was 16 years old who came with an insidious onset of diminution of vision, and it was painless progressive. He had no family history which was contributory. He was a non-smoker, non-drinker with mixed diet, and his nutritional workup was normal for vitamin B12 and serum folate. So this was his vision of 2800 and 1200. So for a young patient, this is really hampering vision for his, or visual impairment for his routine activities. And as you can see here, he's got temporal pallor of both the optic discs, which is looking bilaterally symmetrical. He has a central scotoma, and he's got a severely reduced ganglion cell layer. He's also got thinning of the RNFL temporally on both the sides. Although his history-wise, it was not contributory, he underwent genetic counseling and sequence analysis, and he had a single-point mutation for a 11778 mutation, which is confirmatory for Leber's hereditary optic neuropathy. So then this patient was started on idebenone, which is currently considered the treatment for LHON. He was started with 900 milligrams of idebenone every day, and as we sequentially followed him up, after 1 month, his vision had improved from 2800 to 2500, then further improved to 2125, and at 6 months at the end of the idebenone, his vision had improved to 2025 in each eye. And this is not every case that we see this dramatic vision improvement, but I've seen it in about a handful of cases of 11778 mutations. So although their visual fields or their ganglion cell layer appears to be the same, they do get that tunnel vision with which they are less visually handicapped and able to at least carry on with their studies or education or their routine activities which they need to. So this is another promising drug in cases of LHON. And currently with the rescue trials, they have also confirmed that it should be used for a period of 2 to 5 years, although it is fairly costly, especially given our population where they have to actually pay for the drug themselves. So this was another study which we published in JPOS, which looked at the clinical and genetic profile of Leber's hereditary optic neuropathy. In our patients, all of them were males. They had severe to profound vision loss with a central and centrocecal scotoma and diffuse bilateral pallor of the optic disc. Most of them had a primary single mitochondrial mutation, of which 11778A was the commonest. We also identified one novel secondary mutation within our cohort. Next, we look at some of the IRDs, that is inherited retinal diseases. So basically, when we talk of inherited retinal diseases, there's a lot of other system involvement, and the commonest is the CNS, followed by the ear, the skeleton, the kidney, as shown in this bar diagram. So this was a girl who, as you can see, 13-year-old female who has features of obesity. She also had polydactyly. This 9-gaze photo is not for strabismus, but mainly to say that she also had a Duane's retraction syndrome. And in her retinal evaluation, she had a retinitis pigmentosa with extinguished photopic and scotopic responses in full field ERG. So here we can see the extradigit on both the hands and the leg, the changes of retinitis pigmentosa in the fundus and the extinguished ERG response. So this was a confirmed genetically proven case of Bardet-Biedl syndrome, where we can see it's a syndromic inherited retinal disease. Next, we move on to something which we see more commonly, that is the Usher syndrome. And this bar diagram again shows a decade-wide distribution where it's more common in the second and the third decade of life. So this was a classic case where you can see the features of attenuated vessels and pigmentary retinopathy in the periphery with reduced visual fields in this. And what's important is that there's a lot of phenotypic overlap in these conditions. So we need to check for other similar phenotypic presentations, that is the retinal abnormalities and hearing loss, which can, as listed, can occur in numerous conditions. Then we move on to another baby. This was a 4-month-old child who had no eye contact and roving eye movements. He had high hyperopia and an extinguished ERG. So sort of clinically, it looks as if we are dealing with something like a Leber's congenital amaurosis. He also had Vermean hypoplasia and thickened superior cerebellar peduncles. That is a molar tooth sign, which is very pathognomic of Joubert syndrome. And clinically, I don't know if I can run this video, but as you can see, he's got this head thrust. Now he's much older. He's not 4 months. He's been following up with me for the past 2 years or so. And every time we're trying to show him an object, he has this head thrust, as you can see. So he's got this oculomotor apraxia as well. So I'm just going to quickly run through. These are the ocular and the systemic findings that we see in patients with Joubert syndrome. And this is another important entity which cannot be missed, because we need to involve the pediatric neurologist in their care as well. So this rare case I'd been through before. So this was a patient with cutis laxa who is a 2-year-old but looks like a very old child, a very old person's face. As you can see, because of the lax redundant skin, skeletal abnormalities. This was a non-consanguineous marriage but was positive for a PYCR1 mutation, which is diagnostic of a progeroid syndrome of DBARC. With this, I'm just going to conclude by saying that pediatric ophthalmology includes syndromic, genetic, and inherited conditions, and genetic testing and counseling aids in obtaining a confirmatory diagnosis. We all live in the genomics era, and genetic diagnosis serves as a benchmark, and a multidisciplinary approach helps in the best possible care for the patient and for our families. Thank you for your patient listening.
Thank you for patient hearing. If anybody has any questions, Dr. Manju will be available downstairs for any question. We have to vacate the hall. You can ask her question directly.
Yeah, and let's have a quick photo and then we can move on to questions outside the hall.